Well, hello everyone, and welcome to today's Network Commons. The Network Commons is a live online discussion series developed by the Build Healthy Places Network to focus on cross-sector strategies to improve neighborhood health and well-being. My name is Doug Jutte. I'm the Executive Director of the Build Healthy Places Network, and today I have the honor of serving as the moderator for our discussion. Our topic today is health equity. Specifically, we're interested in how we can continue to advance health equity efforts at the community level within the rapidly changing policy environment that we find ourselves in, particularly the turmoil and policies around public health, healthcare, and community economic development. We've always known that health equity is part of the history and focus of community development. After all, today's community development sector is directly descended from the 1960s war on poverty. However, recent work by the Robert Wood Johnson Foundation to carefully define health equity has brought these fields even closer together. The Foundation's definition that you'll find shortly in the chat box on your screen notes that removing the obstacles of poverty and discrimination while also addressing important social determinants of health are requirements for achieving health equity. This brings our cross-sector work into greater alignment than ever because addressing poverty and discrimination has always been central to the work of the community development sector. Meanwhile, our new presidential administration has proposed a 10-year budget cutting over $600 billion from Medicaid and the Children's Health Insurance Program, or CHIP, suggesting cutting almost $200 billion, or nearly 30% from the Food Stamp Program, or SNAP, and cutting nearly 20% from Centers for Disease Control and Prevention, and tens of billions of dollars in cuts from community development programs, including the CDFI Fund, the Treasury, and most rural development programs. In addition, the proposed American Health Care Act, so far passed by the House of Representatives and currently under work in the Senate, has proposed nearly $1 trillion in additional cuts to Medicaid and reductions in insurance subsidies for low-income Americans, leading by some estimates to over 14 million people losing their health insurance coverage within the first year. However, despite all these looming policy changes, there are more place-based efforts than ever working to advance health equity. The proposed changes point to the need for multiple sectors to come together now more than ever to maintain our forward progress. So based on your answers during your registration process, it appears that most of you are already involved in health equity and are interested in actionable ways to continue your work on the ground and at the policy level. So we hope today's discussion can provide you with some ideas about how to make the case to policymakers and funders for your ongoing work. What we'd like to discuss today are strategies and important points of leverage for organizations and individuals who seek to continue their efforts to promote health equity in communities across the country. Fortunately, we're lucky to have three national leaders with us today who've worked in policy across the U.S. government: the U.S. Department of Agriculture, Housing and Urban Development, Treasury, Health and Human Services, and more. Together, they represent many facets of public health, healthcare, and community development. You can read their details of their full backgrounds by clicking on the links that you'll see shortly in the chat box, but I also want to provide brief introductions. So first, I'd like to welcome Dr. Howard Koh. Dr. Koh is the Harvey V. Feinberg Professor of Practice of Public Health Leadership at the Harvard T.H. Chan School of Public Health and the Harvard Kennedy School. And from 2009 to 2014, Dr. Koh served as the 14th Assistant Secretary for Health in the U.S. Department of Health and Human Services, where he oversaw 12 core public health offices. Next, I'd like to welcome David Lipsetz. David is joining us today from Washington, D.C., where he serves as Senior Fellow at the Housing Assistance Council. David came to the Housing Assistance Council after holding several presidentially appointed positions in the Obama administration, including with the USDA and HUD. And finally, I'd like to introduce Ellen Seidman. Ellen's a Senior Fellow in the Housing Finance Policy Center at the Urban Institute, also based in Washington, D.C. Ellen's held senior positions at the U.S. Departments of Transportation and Treasury, and over the last 15 years, she served on the boards of numerous community development financial institutions, or CDFIs. And currently, she serves as chair on the board for ARIS, which is a national organization that provides financial and impact data, assessments, and ratings for CDFI loan funds. So thank you all for coming. We're really pleased to have you here today. I'm going to kick things off with just a couple questions for our speakers because I want to move quickly to audience questions. I want to thank all of you who submitted questions earlier while registering for the event. And for those of you who want to share questions or comments now, you can use the Q&A option that shows up on the side of your screen. Note that it's separate from the chat box where you'll see some of our material show up. We'll also be following Twitter, so you can send us and the rest of the world messages that way as well by using the hashtag #NetworkCommons, all one word. And we'll try to get to as many of them as we can. So I'd like to open today's discussion by asking each of our speakers to give us a sense for the big picture for promoting health equity in the current policy environment. Dr. Coe, I wanted to start with you. The proposed American Health Care Act, or AHCA, threatens progress on population health work. But based on your decades of experience in public health, including your work to implement Healthy People 2020 and the Affordable Care Act, what's your sense of where we're headed with the future of equity and population health?
Well, first of all, Doug, many thanks to you and your colleagues at the Network Commons for putting this together. It's a very important national discussion. So over the years in my roles as a physician, advocate, professor, and public health official, I've come to learn that if you want to promote health equity, you have to be committed for the long run. You have to have patience for years and decades or more. And so during these times, we have to share a sense of constancy of purpose, but also a willingness to be as patient and as flexible as possible. One of my favorite sayings is, "Blessed are the flexible, so that ye shall not be bent out of shape." And I think that's appropriate for times like this. Now, you mentioned some of my experience in Healthy People and the Affordable Care Act as Assistant Secretary. When I was the Assistant Secretary, I had the great honor of overseeing Healthy People, which many of you are familiar with. It establishes national goals for the nation for the upcoming decade. So I had the great privilege of overseeing Healthy People 2020. I'd like to say that we need 2020 vision for a healthy people and a healthy future. I remember very fondly that that process was coordinated on one hand by our Department of Health and Human Services, but it relied heavily on thousands of leaders who represented the community. And there's a saying in Healthy People that the health of the individual is almost inextricably linked from the health of the community. So that's where today's session comes in. When we were developing Healthy People goals and objectives, we sat around the table with colleagues from housing, transportation, education, justice, environmental protection, and many other agencies. And I think that's how we have to promote health for the future. It has to be community-based, it has to be interdisciplinary, and we need people to understand that health is much more than what happens to you in a doctor's office. It happens in the community where people live, labor, learn, play, and pray. This is a time where we need to bring in as many non-traditional partners as possible. And it's critically important because the Affordable Care Act was signed into law in 2010 when I was Assistant Secretary. And since then, we can celebrate many advances, like some 20 million people gaining health insurance coverage. We all understand that the ACA is much more than health insurance. It's also about building healthier communities, about promoting prevention, and about moving toward health equity in an increasingly diverse nation. And I personally feel very passionate about that as an Asian American and as a son of immigrants. But now, Doug, you've reviewed some of the many challenges that we face with the HCA with respect to funding and other issues. In my view, we need, at times like this, a commitment to bipartisan solutions and a respect for what communities can do. If you haven't seen it, I want to call your attention to a very important report that came up in the National Academies of Medicine just a number of months ago. This one, it's called Communities in Action, Pathways to Health Equity. It gives some 9 examples of community efforts to promote health equity in areas like public safety, employment, education, the physical environment, and housing. Now that I'm back at Harvard in academia, we have a new grant to bring the worlds of private business and public health closer together. So I think these are some of the ways that we can work together during a very uncertain time.
That's great, thank you. We're going to try to link in the report you just showed us so that everyone who's watching can click on that. Yeah, and I'm excited too about your work with the business school. Linking the public health school and the business school is really exciting.
Thank you.
So Ellen, in addition to likely changes in healthcare policy, there's been talk of large-scale changes to tax policy and federal urban policies affecting community development. In this environment, how can practitioners think creatively about bringing place-based projects that they're already working on to fruition?
So first of all, I also want to thank you, Doug, and your team for bringing this together, and my fellow panelists. I think it's going to be really an exciting conversation. Yeah, from Washington, it does feel like all hell is breaking loose, and to some extent it is. But in addition, and in addition to the budget issues that you mentioned, The HUD budget is being proposed for a 13% reduction, which will hit even harder on the community-based issues because of the disproportionate share that vouchers have in that budget. And the tax reform proposals, such as they are, it's really hard to understand what they actually are, have already scared a lot of investors in the low-income housing tax credits. So yes, it is a tough time. Now, having said that, I think it's really important to lean in, not lean out. First of all, the tax proposals are not going anywhere fast. Secondly, the budget is just the budget. Even one senior Republican, Senator Corker, who's the head of the Foreign Relations Committee, said he hadn't even read the part of the budget that deals with the State Department. That's how far from reality that budget actually is. Things will happen. Unfortunate things will happen. But I think what's really important is to push ahead with every single federal funding application that you have or could have. Do not lean back, lean forward. Even if the money will not be there in the future, it's there now, and you need to try to make sure that you get what you justifiably need and deserve for the projects that you're working on. But change is clearly going to happen, so this is also the time to look forward and to think creatively. And obviously there are multiple good reasons that are project-based and programmatic to build partnerships, as Dr. Coe talked about. But going forward, as he mentioned, that's going to be even more important, and it's going to be important to also solve the wrong pocket problem, so that when function A saves money for function B actually gets, I'm sorry, function A, which has spent the money, actually gets some of the benefit. But it's also very important to be involved in the policy discussions in Washington. And I think, for most people out of Washington, this involves coalitions, letter writing, talking to your congressperson, coming to the Hill on, visiting days and things like that. But I think the important point to remember is it's also critically important for people on the ground to be helping those coalitions form the policies that they're going to advocate for. Too often, Washington is in a bubble by itself, and the coalitions advocate for policies that they think will benefit the folks on the ground, but may or may not. And that is just a waste of resources, and it doesn't benefit anyone. And finally, I think it's time to take advantage of the new investors that are out there. We'll undoubtedly spend a good deal of time talking about hospitals as funders, but there are lots of other health partners that are potential players in community development and in place-based activities. Insurers are the most obvious sort of next example. And the entities that are both care providers and coverage providers are leading the way. I also don't think that the broader impact investing is a fad. I think it's real, although the notion that you can earn high equity-like investments, taking no risk, and providing needed social services, that's wrong. But there are still a lot of opportunities for those who are interested in doing well and doing good to invest. The Obama administration left us two important legacies that should help foundations making program-related investments and pension funds subject to ERISA to increase their social impact investments. And while there's still a lot of work to be done to effectively connect potential investors with the projects that need their money, and to fund investment opportunities for those projects to make them understandable and attractive, people are working on it. And the money potentially involved is many times what is likely to be available from the federal government, even when combined with state and local governments. And at least some of it may be truly flexible and unrestricted. And in that vein, the increasing involvement of business, as Dr. Coe mentioned, is just a really important bright spot. So I think there's a lot of opportunity, but lean in and get what's there now, and be creative about the future.
Great, thank you, Ellen. You know, there's a lot of good stuff there to unpack, and I think connecting back to Dr. Coe's effort now is important. The other thing you mentioned, which I thought I just wanted to bring up again, was the wrong pocket problem, where, as you said, savings from the investments of, say, housing that accrue to better health don't end up coming back to
housing.
Create more housing.
Exactly.
But also, it's interesting on that note, and this is a realization for me recently, is that the negative consequences from across sectors can also flow that way. And so if we cut housing subsidies, for example, that will result in more low-income people being unstably housed with worse health. And so what we often don't see is the physicians advocating for housing, for example. They're focused on the Medicaid,
Right.
but not necessarily on the
No, I think that's right. And the same issue comes up in the community development world.
Mm-hmm.
You know, even though the Community Development Financial Institutions Fund was zeroed out in the budget, there's a fair amount of hope that it will be okay.
Mm-hmm.
But if the subsidies that the borrowers of those funds are dependent on,
Mm-hmm.
which come from other budgets, are
Right.
really whacked, then while it's better than everything going away, it certainly will be a big blow.
Yeah, yeah. Great, thank you. So David, you've managed several of the federal government's largest housing and community development programs, and you're recognized for particular expertise in rural community development and finance. So given the prominence of the rural vote in the past presidential election, what changes do you expect to see in policy around investment in rural communities across the country?
Doug, thanks for the intro. And by the way, if we want to stop the conversation right where you were plugging more money back to housing programs, I'm ready.
Stop right there, yeah.
Look, you guys, yourself, Colby, the Build Healthy Places team have been fantastic to work with. I'm excited to sit here with Ellen and Howard as well, and we get a good population of folks that maybe don't have a conversation with a houser all the time. Your question about what's happening in rural and the results of what we're seeing from the previous election, maybe I'll stick to that, because much of the policy conversation, I'll have a few hits at the end, but I think you heard a lot of what we should concentrate on from Ellen and Howard. Most folks aren't terribly familiar with how we define rural and what's happening in a rural landscape that are sitting in some of the big policy centers across the U.S., but most notably here in D.C. We're talking about 46 million people, 14% of the population. Generally, we talk about small towns and cities that are 20,000 or less. 23% of rural America is people of color, and the landscape itself is a pretty fundamental element to defining this. Whereas rural places cover about 72% of the land, built up land in the U.S. And most of that's west of the Mississippi, so about 60% or so is far to our west. The housing stock itself and the way people are housed in rural places is fundamentally different than urban. 80+% of the folks live in a single family house that they own or rent. Homeownership rents are much higher there as well. Unaffordability is at near an all-time high for folks. They're spending more than 30% of their income on housing, which leaves fewer dollars for transportation, health, and other elements. And oftentimes that is a soft market issue, not a hot market issue. And what I mean by that is you'll often see that
technical glitch.
that cities like Detroit and San Francisco, two places that I've lived and worked, are lumped together in the same definitions. A fairly challenging thing when you're trying to talk about trends. Well, the same is true for for small towns. I grew up in part in Montgomery, West Virginia, and places outside Columbus, Ohio. They're lumped together with Taos, New Mexico, and Tuskegee, Aspen, Colorado is rural, Hazard, Kentucky. The differences are broad, but let me try to talk in a few of these generalities. Rural places were growing until about 2010, albeit at a more modest rate than urban. And in 2010, a slight decrease in total population has begun to occur. That trend is continuing, and as well as a trend toward aging. This is not just that there is fewer births for replacement, but there's also an outmigration of our 18 to 24-year-old population to jobs in the city that has picked up. Also note, undoubtedly, income segregation is rising fast across the U.S. We all know that, right? And it has a huge impact on health and well-being issues. It's accelerating even faster in rural places, and when you get the negative impacts of poverty affecting health outcomes, and you accelerate that in a rural place, you are facing some significant emerging challenges. For the rural population, for those health providers out there, this probably sounds pedantic, but I'll run through a little bit of the population that you're more likely to die from heart disease, strokes, COPD, cancer, unintended accidents. If you're living in a rural place, you have higher rates of smoking, higher blood pressure, rates of obesity, you've got less access to fresh foods, activity. You've got a significant number more deaths from drug overdose, suicide, alcoholism. I mean, the challenges that the behavioral and physical challenges to the health of this population is significant and demands the attention. And so that's really why I try to run through my spiel about who is rural America.
Right.
It needs to be a more fundamental part of our conversation. The years that I spent working for the city of New York and the city of Oakland, California, had me thinking that the Bronx, West Oakland, East LA, South Chicago were the places that us, a more progressive community, needed to focus our attention. Well, those problems remain, but many of those places make Appalachia, the Colonias, tribal lands in the southern Black Belt look like veritable launching pads.
Yeah.
They look like launching pads.
You've heard the term rural is the new inner city.
Yeah, and there was a good article in the Wall Street Journal about that recently. So as far as the policy elements that it's affecting, look, I don't think this incoming administration has made many distinctions around geography in making changes to policy. The domestic programs that are being hit hard, including the housing programs that Ellen mentioned as being zeroed out or greatly reduced, are going to hit rural places much harder because of the poverty, because of the health outcomes in those places. So that's going to be a very significant impact. We do have a couple of resources that I would, for policy thinking, health professionals out there, I draw your attention to in the rural landscape. Most are pretty researchy, like the Federal Office of Rural Health. But where I last worked on behalf of the president, it was the Rural Development Department at USDA. And this is a $216 billion portfolio holding development bank. They're originating $36 billion a year in debt to develop hospitals and houses and everything in between. It is a fundamental part of what sustains the rural market and the rural population, the health that it has now. Absent those programs, most of which have an existing market test where if you can get debt on the private market, you may not use these programs. So if market's not serving these programs, if we reduce USDA's involvement in these communities, I really fear for the future outcomes in the rural health.
Tell us the name of that. What's that office again, or what's the? Because we can link that into the chat box.
Oh, and it reminds me that as I sit here at the Housing Assistance Council, an organization that's done 40 years worth of work at getting housing to the poorest, most rural population, and continues to be a tremendous policy contributor. We're also live tweeting this out, so anyone
Oh, good. Okay.
sees rural home and that dialogue in your Twitter feed, that's us, and it should be for my Twitter feed as well. Ruralhome.org is an excellent resource.
Oh, good.
The Housing Assistance Council and others concentrate on the Rural Development Department, or Rural Development Area, Mission Area at U.S. Department of Agriculture. And in there they do utilities, water, sewer, they do business development, we do community facilities, housing, all kinds, soup to nuts in a rural place from community development. So unless you stop me, I'm going to keep going on for more. I think these are important programs.
Well, thank you, David. And just in case, it sometimes can feel like it's us talking about them, sort of urban-rural thing. And I think you all know, but I'm from a town of less than 500 people in Ohio, and my parents have a pumpkin farm there. I've been told my mother I think is listening right now. So I grew up in rural Ohio. So great. So I want to turn to audience questions. I want to thank those of you who submitted questions prior to and during the discussion so far. We received 50 in just the registration process alone. We obviously won't be able to get to all of them, but we've tried to consolidate some together. So please do keep sharing questions using the chat box on the right side of the screen or via Twitter using the hashtag #NetworkCommons. And Rini Roy Elias, my staff here, has just handed me a question. So this is for you, Howard, with the opportunity for Ellen and David to respond. Howard, so what can state and local agencies do to help advance health equity in a concerted way? This was submitted in advance for you.
Thanks, Doug. That's a good question. I've thought a lot about that as a former state health official, as a former Massachusetts Commissioner of Public Health. And I think broadly speaking, if people in state and local agencies can reach out and bring people together in the most inclusive way to share in a common vision, this is the time to do it. And that means bringing non-traditional partners to the table. We in the health world often spend our day talking to other people in health, and this is a time in public health where we need to bring in those non-traditional partners. We have David and colleagues in housing, for example, and we can talk about business and faith-based organizations and transportation and other sectors. That's very important. Identifying the highest level leader in your local or state environment to help do the convening is very, very important. If you have access to a governor or a mayor, that could be critically important. I'll give you an example. In our state, we have a city, Lawrence, Massachusetts, a city of about 70,000, which is very disadvantaged, heavily minority city. And over a decade ago, the mayor of that city established the Mayor's Health Task Force that brought all people together across sectors to talk about promoting population health. The mayors have changed several times since then, but the task force continues. And that heavily disadvantaged city has made some progress, got recognized by the Robert Wood Johnson Foundation for their innovation, so that was great. Another theme, by the way, is when you bring these people together and you try to start on new initiatives, if you can try to identify some quick wins and just prove to people that you can work together and gain success, that is very encouraging for people to keep on going and working with you. For state and local agencies to connect with the National Group of State Health Officers, ASTHO, the Association for State and Territorial Health Officials, or NACHO, the National Association of County and City Health Officials, that can help a lot. And then, of course, if we can lean in, like Ellen was saying very nicely, and leverage new opportunities, that's also very encouraging. So I'll give you one example. The Centers for Medicare and Medicaid Services, CMS, developed an innovation center, CMMI, as part of the Affordable Care Act, and they're doing some very creative things. There's been a lot of attention to accountable care organizations, or ACOs, but many of you may know they came out with a new model for communities that also encourage partnerships and caring for broad populations, and that's called accountable health communities. I was delighted that a couple of weeks ago, even in this uncertain environment, CMS identified some 32 community-based coalitions and organizations to move that work forward. So I think those are some examples of how state and local agencies can work to advance health equity in a very challenging time.
That's great. One thing I'll add, and maybe Allison, who's online for us, can put in a link. We've got on our site a partner finder that actually lists both ASTHO and NACHO that you mentioned, the national and the state and regional city-based public health organizations, so that it's on our partner finder. So those who are listening can find their partners in those agencies. Ellen and David, any further comments about the role of state and local agencies to work together or do this type of health equity work?
I think Howard did it well.
Okay. You're okay, David? All right. So Ellen, next question I got here is for you. How do you get funders of community development to be interested in health equity? This one as well was submitted upon registration.
Yeah, well, I think I want to start with some advice that is important in talking to policymakers about anything, which is you've got to understand what they are interested in, and preferably the language in which they speak about it. And then focus in on how what you're interested in advances what they're interested in. You know, the words health equity may not resonate, but helping all of your constituents stay healthy enough to work a steady job may, especially when you then tie those jobs to a more robust local economy. Health equity in terms of for people who are interested in housing, the notion that a healthy population is a more responsible population, a population that is going to better populate your buildings and what you're doing. It's sort of simplistic, but it sort of gets to what they care about. So I think that in talking with any policymaker, the first step is to understand what they care about and to put your work in their language. And I also when you're talking to somebody who knows their stuff, make sure you do too. There is nothing worse than trying to explain to a policymaker how this wonderful thing could happen if only, and then to have them that I agree, but it's against the law. Now, it is fairly frequently the case it's not against the law, but it's your responsibility to be ready for that and to at least raise some doubt in that policymaker's mind. Second, I think we've spent a decade being told that our policies should be evidence-based, and that's true. But frequently what resonates with policymakers in the first instance is stories, especially stories about their constituents. You've got to have the facts to back up the effectiveness of what you're doing or advocating, but you got to lead with stories and testimonies. And while one-on-one conversations are critical, it's interesting also that stories in the right places, the magazines, newspapers, and media that policymakers pay attention to can really multiply your effectiveness tremendously. And finally, and this is something that I think others have said, but policymakers want to know that you're not alone and that you're an accomplished doer. So be ready to talk about your partners, how long your coalition's been working together, what you've accomplished, and not only what your big goals are, but your recent wins.
So it's really interesting. So you really actually covered very effectively both what funders and policymakers need to hear, which is put it into their terms. And I had a colleague who I met the other day who does environmental health, and he's in Ohio, and he talks to Governor Kasich regularly. And he said he walks in and Governor Kasich wants to know economy and job creation. And so he frames the environmental stuff he does in terms of the economy and job creation. And I think it's very true. So here's another question. This is, looks like it's a David / Howard question. What strategies would you suggest to convince health insurers to participate in and provide funds for these types of community development efforts? David, do you have any thoughts, or do you want Howard to take this one first? Or so we're thinking health insurers.
So one of my favorite pieces that came out during our administration, and Howard probably knows well as well, is if you go to a hospital and they're required to file a 990H, beg them to flip it over to page 2, look at the top couple of lines, and it says to invest in housing as a way to maintain your tax status. I mean, there's really been a number of things that have crossed our.
And that's the community benefit requirement, is that right?
That's exactly right. That's exactly right. In the first line in it says housing, and so much of the literature now is showing us the social determinants of health outcomes have to do with the quality of the home in which someone is raised. So if you take an interest in that population, and if you take an interest in where they're served, then addressing that certainly at the hospital level is helpful. For us, as housers, we often think about one of the main costs to our housing is insurance as well, and opening a dialogue between us as housers and the insurance industry is certainly going to benefit the way in which we as housers can keep people in a healthy and safe home. But the ability for the programs that I manage to perform, meaning we're lending to a poor population that lives in a rural place, they need to be able to pay their mortgage, and that ability depends highly on the two things that your friend keeps talking to my former governor about. And that's, of course, the health of the resident and their ability to get the job. Howard?
So that's a good question. And my response is that, again, to my colleagues in the health world, when we launch any initiatives and we evaluate outcomes, we usually focus solely on health outcomes, which is appropriate and important. But in this environment, I think it's important to also broaden outcomes and do evaluation that measures budget impacts. If you can have cost savings that you can demonstrate from your work, cost effectiveness, return on investment, those sorts of themes, that is really critically important for evidence to present to insurance plans. So I think in short, when we're doing this work that's community-based, the more we stress evaluation, bring in evaluation experts. This is where academia comes into play. Measure outcomes that are not just health outcomes, but involve budget and return on investment. Then we can show that our work not only helps people save lives, but also saves money, which can be a very powerful argument for insurance leaders and also for elected officials.
Thank you, Howard and David. One thing, Allison, who's on my team listening in, why don't you chat in the link to our crosswalk essay on from treating the ill to preventing the illness, because it mentions a couple great examples of United Healthcare, the largest for-profit insurer in the country, investing directly in affordable housing. To your point, David. Also, I just opened up my Q&A box, and I've got a couple things. So Jennifer Levin suggested that she's not seeing the chat box. If you don't see it, there ought to be a link at the bottom. I can see that, but if it's not there, we will follow up, as you suggest, with a link to all the resources. So we'll keep track of what we're sending out and send those out. Dawn is also from rural Ohio, and is working in Central Virginia now, actually. And then I had one very specific question for you, Ellen. It says, Ellen, you mentioned that the Obama administration provided 2 tools to encourage funders to contribute to place-based initiatives. Can you share the specific names of those resources, if you know what I'm talking about?
Yeah, so it's not so much that that they're place-based initiatives, it's that they enable entities to do more social investment with a little bit less of a barricade around it. One was some change to, and I don't have the links, I will get them to you.
Yep.
One was a change in the Internal Revenue Service rules relating to program-related investments by foundations. That makes those rules a little bit less technical and a little bit more oriented towards actually accomplishing programmatic results by foundations with something other than grants. And the second was a tweak to ERISA, the basic pension law, that essentially says if you're getting a market return, you can take social impact into account. Now, one would have thought you wouldn't have needed to say that, but unfortunately, the history of pension investments that do take social impact into account by entities that are subject to ERISA, so that doesn't include the state and local pension funds, it's basically the private pension funds, had cast doubt on that proposition. And the Obama administration clarified both of those issues. I will say there's the question of, how quickly are foundations and pension funds going to take advantage of those changes, but they are there, and they're more important than they sound when you just sort of talk about tweaks.
Okay, yeah, so if you can get us a link to that,
I will.
we'll include it in the follow-up. And this actually, this question came in as you basically have started answering it already, Ellen. So the question was, what's the role of private investment in this sort of health equity work, and especially this cross-sector work between health and public health, healthcare, and community development? And David, maybe you have some thoughts. What's the role for private investment?
One of the fundamental elements here for us in housing is we're obviously engaging a private market for debt to be able to afford the house. I'd love to call folks' attention at the moment to the work of the federal government in doing what's called duty to serve, which is a regulatory structure for our secondary market. Fannie and Freddie go out there and buy loans from your local community banks. They haven't been doing so at a rate in rural places that would suggest that they should by getting public subsidy. So federal government's requiring them to go out and buy more loans. Right now, we're in the middle of a comment period to try to suggest to Fannie and Freddie how to get out there and do that. I strongly recommend taking a quick look at it if you have a taste for that from a public health perspective, and pushing those big secondary market elements toward things that bring more health equity in that rural space. I will, jumping back to something that Ellen said earlier, I do want to suggest that part of the strategy that I might strongly recommend is taking a look at those levels of poverty and need in rural places as they meet the mission of your organization, and talking about that geography to your elected officials will absolutely help you. You alluded to it in your question to me, Doug, that this previous election really opened up a conversation about rural and urban and their divergent paths. And that's true politically as well. And I found when I moved from U.S. Department of Housing and Urban Development over to USDA, my politics changed fundamentally. So with a wink and a nod, I strongly recommend to anyone who's out there that as you find partners in rural places, you'll almost always also find political partners across the aisle.
Interesting. That's good to hear. Thank you. Howard, any thoughts about this private investment role? Have you seen any of that within your work at HHS or now? Well, I mean, you're talking to businesses actually. So yeah, where are you headed with that?
Well, we're just starting to explore what's available, but some of my colleagues in environmental health here at Harvard have worked with investment companies about backing businesses that promote environmental sustainability. And so we're trying to build on that in this new grant that we've had from with Johnson, where we bring private business and public health closer together. So I can tell you more about that as it moves forward, but I mean, that's a very creative strategy that I wasn't even aware of some 6 months ago. So we're looking forward to more progress in that area.
And Ellen, do you have any thoughts about further thoughts of private investment?
I have two thoughts. One is to sort of follow on what we were talking about with respect to policymakers and funders. Businesses also benefit from having a healthy workforce. There's a lot of work that I've been involved in with the notion about businesses having a financially healthy workforce. But frankly, that's the stage 2 to businesses understanding that a physically healthy workforce is essential. And so I think there is work to be done in helping businesses understand beyond traditional wellness programs that, I mean, first of all, spreading those is important, but helping them understand that the wellness is more than just, the physical elements, that it also depends on the environment in which their workers live. The second thing is that to make a lot of these activities work requires money. And particularly if you make this connection between health and the success of the business, the philanthropic arms of those businesses should be available for participation. And for businesses that are in the financing business, they, a lot of those of us who work in housing understand that while to get housing to be affordable requires subsidy and requires low interest rate loans, it also requires market rate equity. And so there are opportunities for people who are not quite ready yet to get into the subsidizing business to be part of the program with market rate investments. And then, if they begin working together, moving into some of the more creative pieces of the system can come next.
Doug, if I can jump
Absolutely.
back into this question, there is increasing attention in the National Academy of Medicine report and other places on the concept of so-called anchor institutions.
I was just thinking about that.
And there are businesses and universities in particular that often employ big percentages of people in a community. So they have tremendous shared responsibility and shared commitment to making the surrounding communities healthier. So there's more attention now being paid to anchor institutions, what they're doing to invest in community health, their leadership in extending what they do in those communities. And I think that's a fascinating topic for all of us to be engaging in the future.
Yeah, no, absolutely. And in fact, again, Allison, if you can keep track of these things, why don't we loop in the Democracy Collaborative is an organization that has really been a leader in the anchor institution concept. And those are, for those of you unfamiliar with the term, it really is institutions that can't pick up and move. It's not a factory, it's actually a university or a hospital in most cases. So they literally aren't going to go anywhere. And it's about hiring locally, buying locally, and investing locally. And it really does, as you were just saying, Howard, and this is true for self-insured large employers as well, is the health of the population around the communities around them plays a role in how much they're paying out for healthcare for their own employees and the families of their employees. So it plays into that. Let's see here. So another question. This one looks like it's for you, Howard. How can we, so elaborate a little more on this, how can we sustainably fund projects that are aimed at social determinants in an environment where we seem to be seeing continued cuts?
Okay, another good question, Doug. And I have several thoughts on that one. I think, first of all, we in public health, when we have any success at all, we need to be more vocal about it. When we have achievements in community building and promoting health of populations and the public, we need to reach out to the media. We need to send the message that this work doesn't happen by accident. It's really vitally important to all people. I thought Ellen made some excellent points about telling stories and also reframing our messages as often as possible to reach different audiences. sometimes we have a health message and we just say the same thing over and over again, but if you reframe how you're saying it, that can reach new audiences. And one example I can give is, I read a fascinating article recently about how we talk about Medicaid, which, Doug, you pointed out, is facing tremendous cuts right now. And Medicaid is very important for funding low-income people and the disabled. But this article was arguing that we should also send the message that Medicaid is a program for protecting our parents and our aging relatives who are facing really tough options about long-term care. And that personalizes what Medicaid is, perhaps in a very important way. And I really, that column stuck in my head. And then Ellen also made another outstanding point that I want to reemphasize. If you're lucky enough to find a elected official or a policymaker who's a champion of your cause, really partner with them, give them credit for their leadership, thank them, stay close to them. So if we find these champions in our work and give them the credit, public credit that they deserve, that can go a long way.
Thank you. Any thoughts on you guys' part? Actually, sort of related to that, we have a related question, which is this idea of innovative funding models. Do you guys have any specific, I have a couple in mind, but do you, innovative funding models, are there ones that you would want to share with the audience today? I'll start then. We'll link in, and this is, there's two that we've often talked about. One is the Healthy Neighborhoods Equity Fund, which actually Howard is in Boston, and is effectively it's to battle gentrification. It's to take advantage of future property value increases in order to get resources now and preserve affordable housing. Another one is called the Healthy Futures Fund, which is a loan fund focused on providing both affordable housing and clinical care jointly, either in the same facility or nearby. And both of those, we'll have Allison link in. That's called Investing in Health, I believe, is the essay we have on that. Other thoughts? This is innovative funding models that you've heard of that we may not know.
So this is David. There's definitely a growth in the type of organization that I've been working with, and I strongly recommend for community development space, and that's the CDFIs of the world, supported through Treasury programs. We have one of our premier experts on that on the panel, 2 or 3 boxes over from me, and Ellen. But in leading to her part of it, I just want to suggest that in a rural space where there are fewer of those anchor institutions that are private, that Howard might have been referring to, there are anchor institutions there that have an even larger percentage of the community development activity going on through them, and often they are CDFIs. Now, when I was at USDA, we had a program of community facilities lending where we had well over $2 billion worth of lending we did in rural places. And if you are at an organization and watching today, and you are in or working with a rural community, go check out the community facilities program at USDA, because it is the cheapest capital you're going to find if you need to redevelop, renovate, or build a health facility.
Yeah, what was that called again, David?
Community facilities.
Community facilities. And someone asked that this question as well. So this whole event is being recorded, and almost immediately after, it's being recorded directly to YouTube. Almost immediately after, we'll have that available and send that to everyone who signed up.
So I'm glad David
go ahead,
gave
Ellen.
me the cue to talk about CDFIs. They've been around so long, it's actually a little bit hard for me to think about them as innovative, but in fact they are. They are financial institutions that are devoted by their charters to serving underserved populations. In rural areas in particular, they tend to have a very broad view of what they are about. And they are really wonderful partners in bringing everyone together and doing exactly what we're talking about, crossing silos, building partnerships, and in lifting up what needs to be lifted up, including the health equity of rural communities. So that's, we will, I think you've got the link to the CDFI fund, and you can certainly search on on the fund's website. They have a Excel spreadsheet, but it's a good search tool, as is the tool that my organization, ERIS, operates, and we'll send that link too.
Yeah, similarly on our site, the partner finder, we've got the Opportunity Finance Network, OFN. Opportunity Finance Network has a search function to figure out which of these CDFIs, these nonprofit banks, function in your community. And we're working right now, we have a draft of an essay on rural community development, actually. One of the great examples is the Hope Enterprise, which is based in northern Mississippi, is doing pretty amazing work. Oh, and someone asked, they sent a chat note in, just as a reminder, and we put the link up. It's the Healthy Neighborhoods Equity Fund. Is that right? Yeah. HNEF, Healthy Neighborhoods Equity Fund. HNEF is the one we were talking about, the anti-gentrification. David, we're almost out of time, but so just quickly, do you have any specific strategies? This was a question that came in for rural health departments in terms of how to think about this. And actually, Howard, you may have thoughts about rural health departments as well.
Well, for me, a lot of it is I'm going to give it to you from the community development and housing perspective, right?
Yep.
And your ability to partner with those in your community who impact the quality of the stock of the housing is a way to get upstream from those health outcomes that are the most difficult and most expensive for you to deal with in your community. In a rural geography, that's a little easier to do. It's a little easier to see the players that you're surrounded by there, but it's going to take a lot of creativity on the part of public health officials and the institutions there, hospitals and other health clinics, in talking to that population to bring them into what we see in these kinds of conversations and in our literature are the determinants of health outcomes.
David, do you have any, or I'm sorry, Howard, do you have any further thoughts about rural community health or public health departments? And actually related to that, someone just chatted in a question about rural hospitals that are at great risk of potentially going under with the funding mechanisms change really dramatically. Any thoughts about what their role is?
On the rural hospitals, there has been a significant number of closures recently, and a growing trend in that direction. The fear that was stoked by the AHCA proposal to adjust the Affordable Care Act has, for the borrowers that I've worked with in rural health networks, has them extraordinarily nervous. We don't have a population in rural places that is accessing employer-supplied healthcare at nearly the rates that we do in urban places, suburban places. And so these hospitals play an outsized role, and a change in the direction of AHCA or however that's going to play out has a lot of the borrowers in my space really nervous.
David or Howard, I keep doing that. Howard, any last words on rural public health departments or rural hospitals? And then we're going to have to wrap up.
You and David have made some very good comments on this issue, and I think one broad theme about rural health and rural hospitals is that when we talk about health equity, geography is a critical dimension, and this is now a time where rural issues are very much a part of the health equity conversation. We have community health centers that serve the underserved across this nation. Many of them are located in rural settings, and then in times like this, we need more collaboration among rural organizations. I know in the discussions about preparedness, for example, when you're looking at capacity of rural health departments or community providers in a rural setting, the more coordination and collaboration you do at a regional level, the better off you're going to be.
Great. Well, thank you all. I want to thank our audience for excellent questions. We are basically at time. So to close, I want to thank the three of you, Howard, David, and Ellen, for joining us today. And for everyone watching, if you missed any portion of today's discussion, as I mentioned, we will be posting the link on the Build Healthy Places Network YouTube channel momentarily. And finally, if you're interested in learning more about cross-sector collaboration and would like to attend future events like this one, do sign up for our newsletter with the link that'll show up in the chat box as well. We look forward to keeping in touch with everybody, and thanks again to the three of you. I really appreciate it. So thank you all, and see you next time.